Hi, my name is Sydney Rao. I'm 22 years old. Today we're gonna fix my Chiari malformation. A few years ago I got an MRI for something else and they found a Chiari malformation. I didn't have any symptoms at the time. Years later I started to get headaches and blurry vision and tingly fingers. So then I got in contact with Dr. Edwards and he's like, maybe we should get you some surgery. And so I looked into it and decided it would be best, that way I can play some intramural soccer and do what I want to do basically. I love to play sports and work out. I'm currently studying exercise science at BYU. I literally took a final today. I'm just excited to have my life like normal and not have to worry about a headache after running a few miles. Now I can just be chill.
Hi. Well, any questions for me?
I don't think so.
Yeah. Are you back in school with next semester?
January 7th.
Oh, man.
I'm registered taking anatomy, so I'm gonna love the brain unit.
Okay, great. Well, they'll take you back here in a minute and we'll get it done.
Oh, thank you.
Yeah. Okay, so I'm John Edwards. I'm doing the Chiari surgery today. I think there's a lot of information available online in various forums about Chiari malformations. I hope that this video clarifies what a Chiari is and what the treatment is like and why we would do surgery for a Chiari. People will say they have a Chiari malformation and the cerebellar tonsils will be like 5 millimeters descended. We would typically not do surgery in that case. Others will have a Chiari that's on MRI fairly significant, but they're not really having symptoms. So we really want to have, for surgery patients that have a significant descent of the cerebellar tonsils, which are the back part of the brain, going all the way down into the spinal canal, and then symptoms such as headaches with coughing, sneezing, or bearing down. They can have some cranial nerve dysfunction, maybe tingling or double vision or vertigo. And then on the MRI, we see those tonsils descended. One specific thing we look for on imaging, which this patient does have, is what's called a syrinx. Normally, the spinal cord has a tiny little channel that goes through it, and there's usually not any fluid inside that channel, or maybe on MRI you could see just a very tiny remnant of that channel. But if that channel is filled with fluid, that's called a syrinx. And patients with a Chiari oftentimes will also have a syrinx. And that's an indication that the fluid dynamics are abnormal, that fluid is not passing from inside of the skull to inside of the spinal canal normally, and it's actually somehow making its way into the spinal cord. And there's debate over the mechanism, but either way, when we see a syrinx, we're much more likely to recommend surgery than in the absence of a syrinx. Or to put it another way, somebody with a significant Chiari malformation that also has a syrinx is definitely someone that we would talk to about surgery. As with every surgery, we either have met with the patient in clinic, sometimes obviously we're meeting with them in the emergency room, but we talk about the nature of the problem, we go through the reasons for surgery and the risks. This is a significant Chiari malformation with a syrinx. It makes sense to do surgery. Risks include spinal fluid leak is one, because we're going to be sewing in a patch graft that we want to be watertight, and spinal fluid can leak out of that. Nausea and vomiting is a very common side effect from surgery, which usually gets better within a couple of days. Post-operative pain is also common. But it can happen that the patients have a little bit of instability of the upper part of their cervical spine as a result of surgery, especially if they also have a connective tissue problem. So we want to be very mindful of that. Infection is not common, but can happen. Other rare problems would be like a stroke or an injury to the spinal cord or brainstem, which fortunately is very rare.
There's a cancellation, so there you go, smile for the
Let's go.
Yep, I'd like to say see you later, not goodbye.
Nobody knows. So, people that have a craniotomy usually have their head put in this. It's called the Mayfield, and it has these little sharp pins on it. So it creates a small hole in the scalp, which sometimes we'll staple after to prevent bleeding. And it seems barbaric. The reason we put people in pins for craniotomies, it allows us to position the head just right. So one of the really important things with a craniotomy is we want to have the head in the right position to be able to do the surgery. Another is there's no pressure on the scalp. So if you're doing a long surgery, now this surgery is not going to take a long time, but if you were doing a surgery that was 3, 4, 5 hours and you had a constant pressure on the scalp, you could actually injure the scalp that way. People wake up all the time, I've got my incision, but why do I have a staple right here? And it's like, well, we didn't tell you, but we had your head in the Mayfield pin. So now you all know. She has nice hair. We just shave a little bit. There's a bump in the back of your skull called the inion, and the incision goes to the top of, or to the inion, and then down to C2, which you can palpate right there. When we prep on these, dura prep's better. It can theoretically run down right into the eye, so you want to be cautious about that. Dura prep is better for the eye than core prep.
You like the slim body stapler for the towels, right?
Yeah, that's fine.
Perfect.
Okay.
We're all kind of trying to figure out how to.
Is it ready? We can do a timeout. Liner. So as I mentioned, the incision for this is from the inion, which is like a bump on the back of the skull, down to the C2 vertebrae, which you can usually feel. And then once we make our incision, we'll get through the skin, and then there's a plane between the muscles that's avascular and it has a little bit of fat in it. So the goal at this stage is to stay right in that midline plane so that the patients don't have as much muscle spasm and muscle injury after surgery. And then can we actually raise the table up just a little bit? The control's right here. And then we just want to not have any bleeding at any point really during the whole surgery, which is, that's good there, thanks. So Lindsay will, if there is a little bit of bleeding, she'll clear the field so I can see where it's coming from, and we'll just stop it as we go. And this is Bovie cautery. It cuts and coagulates at the same time. Really only use the knife just that one time for the skin, and then maybe to open the dura. And she's young and healthy and skinny, which makes the surgery a lot simpler. So I can actually feel C2 right there. So we're in a good place. There's a little bit of muscle there, so I want to make sure that I'm staying right in the midline. And then I'm now on the back of the skull, so that's right where we want to be. Actually burning my finger a little bit.
Were you?
Just a little, because I like to feel, and then
You got a little
like, oh, that's hot.
That's the hot spot.
But you can, well, you may not be able to see on the video, but there's a fat plane right there, which is where we want to be. Cerebellar. These are just retractors that kind of have the right angle and depth, hold the tissues back. Another cerebellar.
Right up.
Could I have the Bovie, please? Oh, thank you.
How many Chiari surgeries a year do you think we usually do?
Probably 3 or 4.
Yeah.
I think every surgeon would like to say they're selective, you know, they're conservative, all that powder. I think that there's definitely a group of patients that need surgery and a lot of people that have a Chiari that don't need surgery.
Yeah.
There's always a little, it's called an emissary vein, but it's a vein coming from the skull, so you can't coagulate it, you have to stuff it with that. This is gel foam, which is a filler, and thrombin, which helps with bleeding. Okay, I'll take a suction now. And then now that we're on to bone, we're just stripping the muscle right off the skull, which I'm sure is part of the post-operative pain from the surgery. Just those muscle attachments are gone. Chiari surgery reminds me a lot of residency because I did a lot of time in pediatrics, and Chiari malformation is one of the principal surgeries done in pediatric neurosurgery. So we did a lot of them.
I think the stories are what makes our job special. So.
Yes. Yeah, because you do the same surgeries over and over and over.
But
It's
the
always
stories
somebody's
behind 'em
unique story.
is what makes them cool.
So now I have the back of the skull exposed. This is actually C1 right there. Yeah.
Oh yeah.
We've got plenty of room to do our decompression. So 4 kerrison. There's always a lot of soft tissues at the junction between the skull and C1, so we're going to take all that off.
A lot of times they wonder, if you remove a little bit of my skull down there, how am I going to protect my brain? You can see there's a large amount of
deep
tissue to go through before you get there.
Yeah, and now I'm biting a little bit of the top of C1 off. I don't really want to take much of it, but just enough to get it out of the way, just that extra ½ centimeter of space without destabilizing the ring at all. This instrument is called a kerrison, so it slides under the bone and then bites. So it's just a hand instrument. Do a lot of work with the kerrisons. Okay, perforator. This drill makes a hole in the skull, and it tends to stop before you go past the bone. So this is a good way to just create a quick hole, get us a gauge of the depth of the bone, and begin doing the craniotomy. The skull's a little bit irregular here, so I'm careful with yeah, it did go through.
Yeah, that's awesome.
Yep. This is single hole to kind of get our craniotomy started, and then we're just going to bite out the bone because the thickness of the skull here is variable. It can be really thick in some places and super thin in others. And so like right here it's super thin, bigger kerrison. So I can just take bites, and I'm going to bite all the way around and then peel off the middle. Oftentimes patients with a Chiari, the bone will be thin because the brain has been trying to give itself as much room as possible. And then in the midline is usually a thicker portion of the bone where there's a keel. So can I see that drill? And I'm going to thin it out there.
Wait till we get inside. The anatomy on this is awesome.
What we're doing now too is it's very safe. I mean, we're just removing bone, 4 kerrison. Our entire day-to-day life is spent in this space between the bone and the dura. So we're really used to being in this space. Every single spine surgery is in this space just about. And it's the intracranial stuff underneath the dura that you would only be doing in a spinal cord tumor or a craniotomy. Part of the bone was super thin, and then this midline keel is
Thicker, for sure.
thick. Okay, 4 kerrison. I'd like to tell you that I'm really tough and my hand's not tired yet, but it's a little bit tired. Drill.
It's
Probably.
actually harder to bite than I would think.
Well, I was so, the initial burr hole in the bone here is so thin that I want to be cautious in how much I drill because I don't want to drill through thin bone.
Yeah.
But this midline keel is
Very thick.
very thick.
Yeah. It is very thick.
Okay, 4 kerrison. Okay, now we're to the other side where it's thin again. So that keel
It's just that thick center.
is right in the middle. I'm just taking the bone off that I cut out. It's not as big as you might think, but it's also stuck. 4 kerrison. Don't throw off my groove, man. You've seen Emperor's New Groove. Beware of the groove. Okay, let me see a needle driver. So we cut just a little piece of bone off in the back of the skull there. We're not going to put it back. It wouldn't heal back. That really gave us a good view of the dura. 4 kerrison. So here we are doing a Chiari malformation surgery, which is basically to enlarge the back part of the skull when it's too small. And so the patient is face down, and we're just removing the back part of the skull. And then we'll open up the covering of the brain or the dura, and then make sure everything has enough space. Maybe coagulate and shrink the tonsils, which is a structure down there that can get in the way, and then we'll sew in a patch and close. So really the surgery is open and then close.
Just that simple from the neurosurgeon.
Yeah.
We're getting pretty close to wanting to have that microscope in. The microscope is my favorite surgical instrument. And I hate wearing loops and a headlight, so for the record, I hate it. Oh, last week I had to because the microscope wasn't working. It was miserable. Actually, let's pull that light all the way that way so the elbow's not in the way. Okay, let me see a nerve hook. Is there a shorter version of this, or is it this long?
I feel like it was long last time.
Yeah. And I just blocked it.
Oh, it went through, maybe.
No. We'll flush that. And I've left most of the muscle attachment on C2. So you can see that I'm just removing a little bit of the top of C1, but most of it's still there. And there's always this band of tissue, part of the ligament, that's nice to clear out of the way. I think the key on the decompression for the bone is not so much vertically, but it's wide.
Yeah.
We want to be all the way to the sidewall of the foramen magnum, which I am there. I can feel that my kerrison won't go any further. So we're really in a pretty good place. Bipolar. Powder. Before I open the dura, I want to have absolutely no bleeding. That way we limit how much blood can get into the spinal fluid, which is an important part of maybe controlling post-operative nausea and other symptoms. So that little bubble you see is the arachnoid. So it's not always perfect, but if we can keep any spinal fluid from leaking until we have the dura opened, we really can prevent virtually any blood from leaking in. And these little sutures just hold and tent back the dura. So it's leaking just a little bit of spinal fluid, which is fine. Dura is really thick right there, right where it makes that transition. And you see, just clear that fill, pick up the teeth, and then that stitch again. So the bleeding's from that sinus. Okay. Snap. We're getting the same thing on this side. So that's more significant bleeding. Take this. All right, where is this coming from? So that's the circular sinus, which you have to open into.
Yeah.
Bled a little more than normal. Yeah, that's a big sinus. It still wants to bleed a little bit. Stitch. But now we got it down to just
A little ooze.
one little spot. And this is all cerebellar tonsil. Like that. Stitch.
Could I get more cryos, please? Or mosquitoes? I think I took all the mosquitoes. Just some cryos. Wrap them separately. Okay. Thank you.
Well, that's good. Okay, now we've got to be daring and open up more up here. But we've sutured it off on both sides now, so hopefully
That helps.
it's not as big of a deal. Let's see the dental irrigation.
Feels like it wants to bleed a little, doesn't it?
What bleeding? I don't see any.
None.
Bipolar. Oh,
You did it.
yeah, it's that corner.
Oh, that corner.
It's always
was
the
rough.
hardest part. Is
You did great.
the reflection of the dura as it goes from. It's always the hardest, and we got it. Now that was a
That was a
little
hard
bit of a challenging sinus. You know that's the hardest part of the whole surgery.
Mm-hmm. Absolutely.
And sometimes it doesn't bleed at all. This right here is the dura. Yeah. Which, for the record, is no longer bleeding. That has a little more bleeding than normal.
A little bit more.
But, you know, you just deal with it and try not to get too worried, or you have to keep your emotions in check. I think poise is a really important part of surgery. My baseball experience, learning how to deal with pressure and be kind of calm and not too worked up about it, has really helped me, I think, in surgery. Okay, so this is the cerebellar tonsil right here. We're not seeing any spinal fluid flow because it's all blocked off by this tonsil. And I want to get the tip of the tonsil. We might need to take a little bit more dura and bone out to get to it. We might not, we'll see. Now you're seeing the fluid welling up there, that spinal fluid. Let me see the scissors. We take a little bit more dura, opening. And then irrigation. Get that, how much that's coming out.
Yeah.
How much pressure that's
Pressure
all
that
under.
was under.
Yeah. This is why she's having this surgery, is
Good.
you'll start to see the brain pulsate
Where it was
when she start.
There it
Yeah.
is. Love that.
There's the back of the tip of the tonsil. That artery right there is an important loop of the pica, tonsillar loop. So that'd be micro scissors. You want to be cautious around that. And we're seeing the back of the brainstem now.
They would only be in that set. Did they have another pair? No?
Bipolar.
Those are straight, and that's just, I use those for surgery. And it's just with, usually curved hair like this. And just hot dry up, I got my hair that.
They're at the warehouse.
Micro scissors. This is great. See how much this one actually goes lateral to the cord.
Yeah, that one's
That's wild.
needed.
Bipolar.
You don't know off the top of your head what the dosing is for MN, do you?
It's 40 orally.
40,
Or
okay.
it might be 125.
Okay. I just haven't ever prescribed it. 125.
Yeah.
Look how cool that is.
Cranial nerves all the way down in there.
Yeah.
Freedom!
You shall be free.
Oh wait, that's copyrighted. I can't do that on YouTube. Wow, that thing was
Huge.
stuck in there.
Yeah, it was.
So was the chicken or the egg? Is it that her tonsils were big, or her tonsils are big because it was tight fit?
We think it's because the back of the skull is too small. Micro scissors. So the tonsils have to grow into some space. And so they grow down. And then they crowd the space that they're in. Bipolar. That was awesome.
Is that something like as an infant? Did they have tortoise?
Yeah.
Did they have a flat head? Did they have like, you know?
I don't know.
You know,
Yeah,
like
good
how
thought.
they had to,
I don't know.
Yeah.
Yeah, does that affect?
I'm sure that there's some associations, but none that I'm like strong correlations that I know of. With that big sucker, be really cautious anywhere near the dura, because that's
It's stronger.
obviously the brainstem.
Yeah, definitely.
Well, if you're going to take a college final, this is a good way not to worry about it.
So how is this diagnosed? Is it just symptoms or MRI? Or?
MRI and symptoms, yeah. Bipolar. It's pretty obvious on an MRI. And then,
So she just lived with it for 20 whatever years?
well, or maybe it became more symptomatic as she got older.
She was saying she had it as an incidental finding. She went for imaging for something else. What I remember her saying to me.
Micro scissors, yeah.
So I can't remember what caused her initial looking
so
into
did
it.
she just have massive headaches?
Some headaches and,
People who did?
yeah, and maybe they just kind of attribute headaches to
Migraine?
migraines or something.
And then this area that you're working on right now, like where are you working? What are you?
Well,
I'm like I'm trying to follow. I'm like, I didn't know what's going on.
yeah, I kind of was wondering if you could help. Anyway, bipolar. So that right there is the back of the brainstem.
Okay.
So that's a good area to not be
This is
messing
why
with
you
too much.
become a neurosurgeon.
You can see the tonsil, there's a notch in the tonsil right there where it was wedged in there.
That's so crazy.
Yeah. Bipolar, or micro scissors, sorry. And there's that same tonsillar loop on the other side. Bipolar. So there's a line in the tonsil.
Opened up my bearings are completely gone.
Yeah,
It's kind of
It's
tricky
confusing
and to understand.
the problem I have is I've just, you're so used to this that you're like, oh yeah.
Yes.
And then you ask people what's that, and they're like, I have no idea. I'm like, oh, well, why not? Bipolar.
And that makes sense too.
Hello, Mr. Cranial Nerves.
I know.
Be free. Bipolar. Or micro scissors.
Little jumping.
Yeah. Sometimes you'll feel the shoulder
Yeah,
fire
it
because
did.
you've got the 11th cranial nerve going up through that
You can
area.
Feel her shoulder.
Uh-huh.
So if a little bit of my bipolar spreads,
Just the heat can make that nerve kind of jump.
That makes sense. Did the body ever like switch on its own during surgery? I'm guessing not.
I think so, yeah. So the vertebral artery is right down there with the cranial nerves draped over it.
It's so cool.
You get some of the most
Beautiful.
beautiful anatomy in a short period of time on these cases.
Look at all that.
Cranial nerves, the
Wow.
vertebral arteries pulsating. You can barely see it, but it's... I should have had that brighter the whole time. Whoops. But that tonsil back was wedged into that
huge.
space.
Yeah.
It's amazing they let me do this. Yeah.
That's so cool. So the big vein in the back is the vertebral.
I
Like
think
just
so, yeah. Artery, yeah.
Oh, that's so cool. I
So
love
bipolar.
this.
So these tonsils used to be all the way down here, and we haven't really removed anything. We've just
Coagulate.
coagulated it, which shrinks it.
What happens if you take too much of the tonsil?
Well, nothing.
Nothing?
Yeah.
Do we need the tonsil in there?
No, we don't think we need it.
So really, so just like our other tonsils,
like the-
we really don't need it?
Yeah, that's why they call it the tonsil. Yeah, you don't need it. Can you clean that?
Which type of malformation did she have?
It's just a Chiari 1, just the run-of-the-mill, what everybody else seems to have that has it, bipolar. The type 2 is associated with spina bifida.
Okay, that's what I was wondering. What this?
I'm sucking a little bit of the tonsil out there.
But not much.
I got my shoulder to shrug.
Got a little jumper.
This is a shoulder shrugging surgery. And then I always ask people what that pink stuff is right there. You know what that is? Anyone? Right there. Does anybody know what that is?
It would make my life if I knew.
Oh, no, what is it?
It's the choroid plexus. It's in the ventricles.
Oh, yep.
We're looking into the fourth ventricle, but that tissue makes spinal fluid. It's also very vascular, so you don't want to. I wouldn't want to be coagulating that much. And then this. So they always get nauseated because the nausea center is like
Right there.
right there. Area postrema.
Can you show that one more time?
Well, it's just in this area here, the floor of the fourth ventricle and the brainstem. But you can see how this is the back of the brainstem and into the fourth ventricle. The spinal fluid's coming out of that.
Mm-hmm.
Sometimes we'll see a little web there that's creating the syrinx. I think we're done with the decompression. So now we're going to sew the patch in, but it is quite lovely.
Twice. It is beautiful.
And everything seems a lot more relaxed, especially me because it's not bleeding.
Can I open the dura guard now?
Yeah, other than that sinus, which we had to get through,
What really was?
it went smooth. And she needed it. I mean,
She needed it.
that was really,
Compressed in there.
this is a good litmus test for any bleeding. If you can fill the wound with irrigation and it's crystal clear, you know you don't have any bleeding. This patch oftentimes looks like a little heart, so this is done with love, of course.
Do you want these, or do you want micros? How about,
We'll just cut these as we go.
Oh, good. I'm glad they found it. Oh, you know who it was? Amelia had that.
If you can cut them a little bit shorter, that'd be
sorry.
good. Yeah, you're good. Pickups?
Set up.
Another pickup?
That was
I'm going to orient this patch differently. This is perfect. Okay. Oh yeah, look at that. Stitch. So we don't want spinal fluid to leak out of this space, but we also, I mean, it would be really hard to close the dura given that we opened it, sutured it back, coagulated it a little bit. And if we close the dura, we might narrow down the space we just opened up. So this patch blocks spinal fluid from leaking and keeps that space open so that it's now a larger space.
is that better? Do you like it or
I
not?
don't know how to use these very well.
Okay, there you go.
There you go. So we're sewing it in. You can run the suture, meaning you put like a baseball stitch which is great. But I've actually kind of enjoyed one suture at a time. Each one is tight and independent of each other, and just a little bit of arts and crafts.
I have the Sunday school kids in their class. They're 6 and 7-year-olds, and every year I do like a Christmas tree that has like the kind of the meaning of the symbols of Christmas, you know.
Yeah, it's perfect, Lindsay.
You know what they mean.
Okay.
Christmas. Anyway, they were so excited. They're just always like, it's so exciting. And then the older kids that have been in my class and come back, or that they'll come and tell me, like, put my Christmas tree up, and it makes me so happy. And it's such a cute thing. That it's like, you know, it's just a Christmas tree, and then it has like, you know, I've gotten like, you know, a little star and a, you know, a bell, and a, you know, just what
all the
those
little
things mean,
things.
all the Christmas
Yeah.
symbols, and those are little ornaments for them.
But how long did it take you to feel comfortable working under a scope?
When I was like 3 years old,
Oh, okay.
yeah, I was pretty much born with.
I knew it.
Just kidding. Oh man, I remember the first time under the microscope as a resident, and I'm like, oh my gosh,
It's so
I'm
weird.
never going to be able to do this.
Yeah. It just,
It's so disorienting.
and I feel
it-
like depth-wise, you have to kind of get used to it.
Yeah.
That's what I have a hard time with.
It's so different. Now I kind of forget about that because it really is kind of second nature.
Then now you're so used to it, but
Yeah.
yeah, it's one thing where I really wish I was better at. I almost want to like just come practice on a scope
One of the best things for being under the microscope was this very surgery, sewing the patch in under the scope.
Yeah.
And the attendings were more likely to let you do this as a, early on in residency because, if you throw a bad knot, it's no big
It's gonna
deal.
be
They
okay.
can fix it.
Yeah.
And so that's another reason why I kind of like this surgery is that there's a nostalgia to it. It's like, okay,
I got good
I
at
can do
it.
something under the scope because
Yeah.
sewing under the scope is, if you can sew under the scope,
You can do
a lot of
anything.
things.
Yeah. I feel like it's a talent for sure.
tying a knot, all that stuff. So yeah, because you do the pediatric rotations. Usually you do two. I did 2 rotations. One was early on, and one was a little bit later. But
So cool.
a lot of my early microscope experience was on pediatrics, and definitely, doing Chiari malformations. I still remember Dr. Smith, who's awesome. She would tell me I was traveling too much,
Oh.
meaning
Did everything go okay?
putting my sutures too far apart.
Oh.
What?
Just the case with Kristen, everything went great, right? I wasn't in that
Yeah.
one.
Oh, yes, yeah.
Kristen.
It went great. Yeah, she has funny anatomy, so the stealth was super helpful.
Oh, good.
The other really cool case in the pediatrics was, obviously there's the posterior fossa tumors in this very space, but those are kind of sad.
Yeah, I wouldn't want to.
But then you had tethered spinal cord,
Oh.
where you'd go in and cut the phylum
Uh-huh.
in like a 5-year-old, and those were kind of fun.
Yeah, that'd be cool.
Because you'd open the dura, you'd take the neuromonitoring, make sure it was the phylum, you'd cut it, spring out of view,
Uh-huh.
and then close the dura under the scope.
Oh, I bet
Take
that'd
the
be
scope
really
out, and it looked like this little minuscule closure with all these little sutures that you'd thrown. It's kind of
fun. That's cool.
very satisfying.
Yeah, I bet. Huh, that's so cool.
Yeah.
And then you did the cranial vaults, obviously.
Uh-huh. Yeah. Those ones don't require the scope.
No, they don't.
And somehow they required like 6 surgeons because there's the fellow and the
Really?
other fellow and the neurosurgeon and the plastic surgeon and the resident and the other resident and
All of the above.
a little bit of a
Crazy room.
craziness. I did not love those in residency. I like them now because it's just me and the
Yeah, because you just have your routine. and
plastic surgeon and
Not 10 other people trying to do it.
it's very quiet without the music.
It is so quiet.
This is our level of dedication for these YouTube videos.
You
That
have
we'll
to
do
be
it without
willing
music,
to listen.
just not very often.
It's funny though, because that's my norm. So every time I'm in here, there's no music.
And so you're like, this is what
Yeah, I'm
it's
like, yeah, this
That's why I didn't want to see you today.
like. You knew there was a reason, huh?
Just kidding.
Well, when I walked in, I was like, man, it is way more fun with music.
Yeah. The music does make it fun.
I think it's good to video though, because
Oh,
patients want to know. There's
And
no
isn't
better
this-
way to help them understand what they're getting themselves into than this. And then they're like, okay, I understand that.
Is your Chiari video still the most viewed?
Well,
or is
not
there no way?
anymore. There's a glioblastoma one.
Oh, the Glio one. That's the one.
But
that
the
won.
day in the life of videos have been more popular. I think it's still leaking a little bit at the bottom, which,
Right
yeah. See if I can.
Oh, I'm sorry, I took your.
Okay, stitch. I definitely need to get this bottom part better, but now I can.
Yeah, so I looked at some when I do older video for YouTube. Yeah.
You can just silence it.
I'm sorry.
Oh, I was telling him.
You
to
cut
go.
that?
You can.
I had music that.
Scissors. A lot of these I tied in knots into. Okay, we're going to do what's called a Valsalva, where you hold the breath for a second and see if we see any spinal fluid come out. Go ahead. You see this is tenting up here, but I don't see any leaking
No.
anywhere.
Really good.
So that's great. Okay, you can stop.
Okay.
Okay, the next thing I like to do is this Surgicel. So this is just a little matrix that platelets can bind to and help seal this off completely.
Sometimes they'll use a piece of gel from bonded in it to.
It's like a blood patch, right?
Yeah.
Okay, scissors. And then this is like a extra layer of, makes me feel better mostly, that called Dura. You don't sew it, you just kind of lay it on. And maybe it helps seal it off even more. And I can tuck it underneath.
12, 14, is that all?
I kind of want to tie some.
Let me get this one more,
Okay.
because this is the top, but I just want to get it really tight, and then, yeah, and then you can tie.
Perfect.
Yeah, there we go. Oh, whoops.
You're fine. See? We're missing two.
Two up.
Can I have more of these? Yeah.
What are we missing?
I think,
Okay, good.
we have 87. Please draw your number.
I didn't get this lined up perfect, so I'll have to,
Mess with it a little.
yeah, a little bit.
That'll work. I'm gonna hold it like that while you.
I'll get this deeper layers finished up, and then we'll have to kind of,
Mess with it.
yeah.
Will it good for you?
No.
You can, there's only a couple more left there, but Lindsay's pretty good at getting the patient out of pins, which gives me a minute to do the operative dictation and talk to the patient's mom, and there's always a few messages that get sent. I turn my phone off during surgery so we're not distracted at all. Maybe we just go to talk to the patient's mom real quick. Hey, are you really quilting?
Well,
Yeah, well, we've both been sewing for a while because a lot of the surgery is actually sewing.
yes, this is we're done.
We're done.
This is.
And it went really well. It went well.
Okay.
Yeah. Yeah. And I think she really needed it. The tonsils were all the way stuck down where they shouldn't be. It's good.
So no problems for the rest of her life, right?
Yeah, I think usually the patients don't need another surgery for this. But they usually do have some persistent soreness in their neck or maybe some headaches that come and go. So it's not like the expectation is symptom free. Yeah, but I would say that the symptoms that she had before surgery, once she's recovered, should be a lot better for the long term.
Okay.
Yeah, but it went good.
Okay, good.
Yeah, she'll be upstairs in an hour.
Okay.
Yeah, so you have an hour to finish.
That's about right.
Do you need me to help? I
No,
can
she's gonna be-
give me a needle driver and some suture, and I can sew.
That's pretty good.
No, I
Honestly, they counted up the needles for the surgery, and it was over 100.
How long will her scar be?
It goes from the bump on the back of your skull down to the C2, so
like
it ends up being about that long. Well, you guys are
Thank you
amazing.
so much.
We'll be by to check on her tomorrow, and that's the first time somebody's been quilting during surgery.
Yep, one day post-op, I'm just laying here every day basically. Got a CT scan at like 5 a.m. I've had a lot of nausea, so the doctors are trying to figure out a pill that I won't throw up. And I'm trying to figure out pain and make it not hurt so bad. It was weird waking up with a tube in my throat. It was nice to know that it's over. Excited to see what's different and what will improve. I'd say just know it's going to hurt, but it will be worth it. Probably I'm not there yet, but make sure you have someone with you. My mom slept with me last night in a very uncomfortable chair. I think 100% just keeping going and trying. Like walking, I feel super weak, but I know that it's gonna help me recover faster, so I think that will be super helpful. And moving and getting the stiffness out of my neck. I'm hoping to feel more strong and being able to eat. I've only eaten like 2 crackers, so hopefully I can eat something and not throw up and not feel super dehydrated.
Sick of seeing me yet?
No!
I feel like we've got to hang out quite a bit. So how are you feeling?
Good, way better.
Way better.
Look, I can turn. That's what I'm most proud of. I can turn my head.
That's awesome.
It's like when I show off to everyone, I'm like, I can drive myself.
Nausea?
No, I'm eating like normal.
Do you mind if I take a look at that incision?
Of course.
Oh, it looks so good. Has it been draining at all?
No.
Any issues with it? Is it still tender?
Not so much tender. I would say like stiff, but that's because it's like the skin has to like stretch again, I guess.
It's not red. It's not draining.
No,
Seems
like I
it's
don't feel
completely closed.
pain with it at all or irritation at all. I've been putting Vaseline and stuff on it to make sure it stays moist.
And then how about neck pain?
Neck pain is really like not there, honestly. I only take Advil just to sleep a little bit because when I wake up it's like stiff after like the whole day and like resting and stuff. But like honestly, like not really stiff. Like yesterday I was really nervous because I was gonna have to hold up my head for like the most I have because of school and work. But like at the end of the day, it was tired. Like my neck was kind of tired, but not like, oh my gosh, I'm in so much pain. It was just like, oh, it's been a long day. Like I had to rub it out a little bit.
And that's
fine.
pretty typical.
Yeah.
And I would say that if you're already doing those things,
Yeah.
you're ahead of the bell curve. So you're doing really well. I'm super excited for you.
Yeah.
So the question is have you noticed a difference as far as pre-operative symptoms to now?
I mean, I haven't had any headaches. I feel like the big test for that one is going to be once I start working out. But like with the vision one though, that one I feel like is completely gone. Like I feel like I've been able to see like normal and I haven't had any blurry vision problems. Definitely no tingling of like the toes with the spinal fluid. I still have the hand tingling
Just
from
that
the
right
nerve.
hand?
Yeah.
Tell me, where does that follow? Does it follow a certain pattern? Like
Yeah, so it's like starting here. I can tell it's better on my arm because it was more tingly before in my arm, but like I still feel it mostly in these 3 fingers, but a little bit in these 2.
And is it transient at all? Like does it come and go or wax or wane
It's
in
like
severity?
always there, but there are times where I feel like it's less and times where it's more.
Okay.
But I don't know what
Yeah, I
causes
mean,
it.
when we're working in that system, just
Yeah.
everything can be inflamed and aggravated. Sometimes it's a positioning thing, the way your arms were held for the operation. But if you feel like it's getting better, my assumption is it will continue to get better. But we can closely monitor that. That's pretty simple.
That's what I've been paying attention to mostly because I'm like, I don't want another problem from a surgery that's not related.
But it's not pain, it's just numbness,
It's
right?
it's literally just numbness. Yeah.
Still full dexterity as far as like...
Yeah, like I can still write, it just feels weird because it's like tingly, but I could still do what I need to.
I mean, we're going to see you again, so we'll keep an eye on
Yeah.
that. And if that seems to be getting worse, I'd want you to let me know. There's some further workup we could do if we feel like it's necessitated, but...
Shock it back to life. I don't want to do that. Nope.
So the incision's healed, headaches are improved. We haven't really tested the waters there, but my question to you is like during this kind of, because of how fast everything kind of transpired, like after surgery, I mean, is there anything that kind of threw you off as far as recovery goes? Anything that was...
I mean, probably the nausea for the first few weeks. Like I didn't expect that, but I'd say that was the only thing that was hard, not getting to eat.
And was it nausea and vomiting, or were you able to control the nausea?
The vomiting came in like an instant. Like there was, after the appointment that I last had with you, I threw up again that night, but it was so random.
Because you had thrown up that morning.
Yeah, but that was like nothing, and I had eaten during the day and felt nothing, and then I took literally 1 bite of an apple and just was like, I'm gonna throw up, which was so random. But then after that, like I felt fine. Like I didn't ever felt nauseous again after that, so it just kind of went away. I don't know.
Yeah, the nausea center is right in that area, so I just think that we expect you to have nausea.
Yeah.
We try to control it the best we can.
Yeah.
You kind of got to work through it.
Yeah.
And a lot of people, they will, I mean, over
Yeah.
time. So I'm glad that you're one of them.
Yeah.
Sounds like you haven't thrown up.
No.
I don't have any restrictions for you. I think you can
Awesome.
continue to do what you want to do.
Okay.
Incremental
Okay.
always is the thought process there.
Yeah.
And I think with working out, you could start with minimal weights and
Okay.
start working your way up. And
Yay.
see how you tolerate. I think it would be good to maybe check in about 8 weeks just to
Okay.
make sure that things
Yeah.
are going well.
Sounds
If
good.
everything's good, we'll cut you loose and let
Yeah.
you kind of follow up as needed probably after that. So.
Sounds good.
Well, good. Well, if you don't have any more questions for me, I'm going to let you get out of here. I'm going to have the MA come in and just
Okay.
get a follow-up schedule in about 8 weeks, okay?
Perfect.